Hi there. You walk into a wound care visit and you clean the wound, you change the dressing, and you write wound care performed per order. The problem is Medicare doesn't care really what you did. They care why skilled nurse was needed and why the wound still requires ongoing care. So let's fix that using a simple framework. Condition, risk, skilled action, response, and continued need. Imagine you're seeing a patient with a chronic diabetic foot ulcer. Today, you observe moderate seroanguinous drainage, slight increase in periwound redness, wound bed appears slower to granulate than last week, and patient reports increased discomfort when ambulating. Most nurses document the wound description and just move on, but Medicare is asking for different questions. Why does this wound require a skilled nurse today? Well, step number 1, the condition. Ask yourself, what is the most clinical significant finding today? Well, in this case, it's a chronic non-healing diabetic foot ulcer. Increased drainage, periwound erythema, delayed healing trend. This is not just a wound. It is a non-healing wound with potential deterioration. Step number 2, the risk. What bad outcome would happen if this continues? The patient is at risk for wound infection, cellulitis, osteomyelitis, going back to the hospital, and possible amputation in severe cases. Now the wound has weight. This is no longer just skin breakdown, and it's a high-risk clinical condition. Step number 3, the skilled action. Why was a nurse needed today? A family member can change a dressing. A nurse, they can assess wound progression, identify signs of infection, determine appropriateness of current treatment, measure and document wound changes, and make clinical decisions about escalation of care if needed, and communicate with the doctor or wound specialist. Now that is skilled nursing. Today's skilled actions may include full wound assessment and measurement, evaluation of drainage and periwound condition, sterile dressing change per protocol, reinforcement of offloading techniques, and patient education on infection signs and symptoms and glucose control, and the doctor notification of wound changes if indicated. Step number 4, the response. What happened because of your interventions? Maybe the patient demonstrates understanding of infection warning signs, verbalizes the importance of offloading pressure, and requires continued reinforcement due to limited adherence. Document those responses, and it proves your intervention had clinical impact. And then step number 5, continued need. Why are future skilled nursing visits still necessary? Well, this patient continues to demonstrate non-healing wound progression, ongoing risk of infection, and need of skilled assessment and monitoring. Need for wound management adjustments and education. Now, that's your justification for continued services. So, putting it all together, let's turn it into a clinical narrative. Patient with chronic diabetic foot ulcer noted to have moderate seroanguinous drainage with increased periwound erythema compared to prior visit. Wound appears to demonstrate delayed granulation and slowed healing progress. Skilled wound assessment performed, including measurement of the wound, the dimensions, the evaluation of drainage characteristics, and peri-wound skin integrity. Wound care provided per protocol with sterile dressing change completed. Education reinforced regarding infection prevention, offloading techniques, and importance of glycemic control to promote wound healing. Patient verbalizes understanding of infection signs, but continues to require reinforcement regarding consistent offloading and blood glucose management. Doctor notified of wound status changes for further evaluation as appropriate, and continued skilled nursing required due to non-healing wound and risk for infection and need for ongoing skilled assessment and wound management. Now, the Medicare reviewer perspective, this is how they see. They see a condition. It's a non-healing diabetic wound with worsening signs. Risk: infection, hospitalization, possible amputation. The skilled need: wound assessment, clinical judgment, and treatment evaluation. And then the skilled intervention: dressing change, assessment, education, and coordination with the doctor is needed. And continued need: wound is not stable and requires ongoing skilled monitoring. Now that is what supports payment, not just the dressing change itself. So in closing, the next time you document wound care, don't just focus on the task. Focus on 5 questions. What is the condition? The risk? Why are skilled nurse needed? And what skilled action occurred? And why are skilled services still required? When you think this way, your documentation stops being task-based and becomes Medicare defensible clinical reasoning. I hope this has helped you out some. Consider subscribing, and there's resources on the channel description. Hope you have a wonderful day. See you on the next one.